This meeting will now come to order. The clerk will please call the roll.
Mayor Carlin.
Here.
Vice Mayor Binsbacher. Here. Councilmember Patena.
Here.
Councilmember Edwards.
Here.
Councilmember Finn.
Here.
Councilmember Hunt. Here. Councilmember Leone.
Here.
Council Liaison Bowden.
Here.
And Council Liaison Camacho.
Thank you. Good evening and welcome to the Peoria City Council special meeting of May 3rd, 2016. We have one item on our study session agenda tonight, and it is Community Paramedicine, the pilot study. So I'll turn that over to City Manager Carl Swenson.
Thank you, Mayor Carlin, council members. As you're all very well aware, the city is moving into the medical service delivery area very aggressively and purposefully over the next few months and years. And one of the areas that we're moving into is what we term paramedicine. And as you know from all of the study sessions and workshops that you've had on this, that this is a complicated area. It's an area that is very important to our citizens, and that's why the city is moving into this area. But it's a complex area, particularly under the Affordable Care Act. Some of the requirements and changes that have occurred in the medical field play out really literally at the street level, you might say, in a city with the kind of response that we're now beginning and many other cities are beginning. So one of the things that we're a part of now are some consortiums and groups of other cities that are working on the same kind of issue. And what we have here is an opportunity to partner with communities in the West Valley, other cities in the West Valley that are also embarking in their own way and in their own fashion, but to a similar point on getting into this community paramedicine field. So what the chief and deputy chief are about to present to you is this one of these partnerships and a grant that we've been able to receive along with the other cities in this partnership to help us collect data and understand better the populations that we're going to be serving as we move into this area. So I know that sounds rather complicated. I think as they explain it, it'll make a lot more sense than my brief overview. So with that, I'll turn it over to Chief Reese and Deputy Chief Bratcher.
Mayor, council members, thank you for having us. Good evening. Excited with this program that we got a grant for, and we is the West Valley, and it's a study in the West Valley with 5 cities, and the study pilot is directed in studying the effects of an EMS prevention program that would have an effect on the high-frequency users of the 911 service, that population. The study pilot is a grant that was given by the Vitalist Health Foundation. Previously, it was the St. Luke's Health Initiative, and it's for $125,000 to study ways that we could reduce the users of the 911 system that use it on a repeated basis. Goodyear, City Goodyear is the administrator of the program, and the 5 cities or districts or jurisdictions that will be involved is Goodyear, Avondale, Sun City, Surprise, and Peoria. The control group that we'll be looking at is the top 10% of the high-frequency users of the 911 system. And that's defined by a frequent user is defined as a person that uses 911 system 3 or more times a month or more than 12 times a year. I think this is yours.
Mayor and Council, just a brief overview of the community paramedicine process or the concept, and it is being also referred to as the top of the slide indicates mobile integrated community health care concept. The whole focus is to avoid unnecessary emergency room visits and improve the quality of life. That is the overarching umbrella. Within that, we can provide cost-effective health care It is a proactive approach rather than the traditional reactive approach. Right now, we have a reactive approach. People call 911 in a crisis, we respond, we react. The community health care is to intervene or make contact with that patient before the crisis and be proactive to prevent the crisis and the reactive response. In a way, it's EMS prevention, and we've talked about that. For years in the fire service, we've done fire prevention. We still maintain at ready, because we know fires will still occur, our emergency response capabilities, but we also focus, in fact, we have a whole division that is fire prevention to stop the fires from occurring. We can think of this as EMS prevention. We will still have emergency resources ready to respond, but on the other end, we want to keep the community healthier or provide for resources to avoid those crises and the reliance on the 911 system. In short, and this is the national mantra now, and it makes a lot of sense, it's right care at the right time in the right place.
Mayor and Council, what you see before you is the cycle, the frequency use cycle. It usually starts off with a crisis, and then the user calls 911. They call the EMS provider. They get transported to the hospital, treated and transported to the hospital. Hospital then treats, and maybe even surgery that they go through, and release them with a whole lot of information, a myriad of information. They go home, and at that point, they're sometimes confused with all the information that is given to them. In other cases, they go home and have no resources to get their prescriptions filled. And so there's a whole myriad of reasoning, but there's limited follow-up with these individuals. So without knowing the resources available to them, is usually they resort back to calling 911, and the cycle starts all over again. This program, this study, is aimed at breaking this cycle somewhere around the home area of when they get released and go home, is to go visit them at home. And again, it's looking at a realistic 10% of those individuals that are reusers of the system. In real numbers, when you look at it, is in Peoria, we have probably 100 to 120 frequent users. And they're in the Pine District and somewhat in the Ironwood District. And so we're looking at 10%. So you're looking at, in Peoria, we're looking at about 10 to 12 individuals throughout the course of this study. So it's practical, it's realistic, and we hope to learn a lot from the study. And hopefully we reduce the number of the overall frequent users, or at least give us information, some data, how to reduce the number of the frequent users. Because if you look at the average frequent user using the system about 12 to 15 times a year, times 100, that's 12 to 1,500 calls a year that overtax, one particular area, one particular station, and reducing that is quite an impact to our folks as far as saving the burnouts and keeping the high level of service within our community.
Mayor, Council, just to kind of go over some local data, and this is from some Medicare numbers, but we know the West Valley has the highest readmission rates due to a recent study by the Health Services Advisory Group, and we'll talk about them in just a little bit. We'll mention them. The zip codes with the highest readmission rates are located in Peoria and Sun City. And we know of those people that are readmitted to the hospital, that 36% of those, the largest majority, readmit within 1 to 7 days. And that's what Chief Reese was alluding to, they come home, they probably need additional resources or help with navigating that, and end up getting back into the crisis situation and readmitted to the hospital, and that cycle repeats again. This getting back to the right care, right place, and right time, and I will, admittedly, this is a very complicated infographic. That lends itself to what City Manager just mentioned. It is a complicated system. It is a national graphic that is being utilized to identify the future of EMS, emergency response services. So we've put it in there, but to kind of narrow it down for you, if we look at the center, that is the patient, and it is a patient-centered, patient well-being system. And the complexity, you can see all the moving pieces coming off of that. To focus on the outside is where we really are. And if you look at the right side of the graphic, the pink shaded area, that is what we do now. That is our emergent reactive response to the 911 call, the treatment, and then the transportation to the hospital. The whole community paramedicine is focused on, and the other projects such as the ARV are focused on completing that circle over to the blue side, helping the patients navigate through the system, providing prevention, and integrating with back into the complete circle, and again, focusing on the patient treatment, patient care, patient well-being. This grant came about through about 2 years' worth of discussions that we've been moving through. First started with the Health Services Advisory Group, and that is a Medicare-funded not-for-profit that is basically charged with reducing hospital readmission rates. They've been very instrumental in bringing groups together, and part of that group, we were able to build relationships and with the Vitalist Health Foundation, and as Chief mentioned, that recently changed from the St. Luke's Health Initiative. They are a Phoenix-based foundation. They're focused on improving community health throughout Arizona by identifying root causes and greater issues that affect health care. They recognized our presence in the community with the fire-based EMS and the systems we had, and our focus towards community and community paramedicine fit their definition of improving health. So we've been fortunate enough to go through the grant process and be awarded the grant process from Vitalist, and we wish to thank them for that. Details of the grant specifically, Goodyear is the primary grant recipient. Fire Chief Paul Luisi was one of the primary contacts and spearheaded the project. From there, we are all participating with IGAs for the disbursement of the funds between the five jurisdictions. The total grant amount is $125,000 over 1 year. The majority of the funds will go to cover staffing and training costs, so there will be no additional impact on staffing and training for the personnel that we need to put into to be the providers of the community paramedicine. The grant will actually fund in July of 2016, and that's when the grant cycle will start. The funding plans will be operating 2 community paramedicine units, one south, obviously, Goodyear and Avondale, and one north, us, Surprise, and Sun City. Our commitment would be no more than 20 hours per week. The total between the two would be about 40 hours a week. And as I mentioned before, the staffing costs are covered in the grant. Another focus of the grant would be to develop a regional training curriculum. And this is a curriculum that we could utilize in the future, and we want to share with other municipalities that are interested in getting into this. Several other municipalities have started to develop or have community paramedicine programs. We want to see if we can basically integrate that and have a regional approach to training for community paramedicine. And another, probably one of the most important things is data analysis, gathering the data, seeing how effective we are in achieving our goals or expected goals for community care or patient care. As Chief Reese mentioned, we'll focus on the top 10% of frequent users of the 911 system. The actual field implementation will be about 6 months under the grant funding. The time will be spent for training, curriculum development, the 6-month field project, and then data analysis after that. We want to basically try to provide resources or connect people with resources that already exist, probably more appropriately in the community, in the healthcare system that they may not be aware of, and to provide education to the patients to decrease the reliance on the 911 system for primary healthcare needs. Also among our goals is to provide ability to consistently provide service across jurisdictional borders, and that is drawn a lot of attention. We would be, and I'm skipping down to the last bullet point, the first regional community paramedicine program in the state. And that has significance when we talk to community partners in really defining community, which sometimes crosses jurisdictional borders, depending on that definition of community. Develop the regional training materials, and then look at the data and try to extrapolate true cost, true savings, true value, and true how well did we serve the patients, and then report back with that data and move forward with future plans. We're very fortunate to have some partnerships. One is the regional partnership, and we will provide administrative support. We are providing existing vehicles, no new vehicles. We're providing existing equipment to operate the pilot. Sun Health Services, which is also a not-for-profit here in the West Valley, is another partnership that we developed through our meetings. They are going to support us with training, and they've been very active in the community with wellness and prevention, by the way, sample patient education materials, and other community resources that they have within their organization or they can link us to. And lastly, the Bob Ramsey Foundation for Social Justice, Star West Technologies, has agreed to provide specialized software at no cost so we can actually gather and manage data as we move through this and have reliable information to bring back at the end of the pilot. Tying it all together, it is basically service delivery connections. And if I were to draw arrows, I'd draw an arrow from where we're at now with Peoria Fire Medical Department and patient connections directly to the hospital. We're moving in the direction of drawing an arrow out from each one, from the center to doctors, urgent care, clinics, other healthcare resources in the community, home health, treat and refer is on the horizon, into coordination with hospice and making it a full service response to the community, both urgent, reactive, and through community paramedicine, non-emergent but proactive. And thank you. We'd be happy to answer any questions.
Well, that is a lot of information. Council questions? Councilmember Finn?
Thank you, Mayor. A couple of questions. The total grant was $125,000, is that correct?
Yes.
And then there's 5 cities that are going to split that
Correct.
125?
Correct.
Okay, so if I have, I don't know what our portion would be, I just was trying to do the very quick math in my head of 1 FTE, it sounds like it's about 6 months.
It wouldn't be an FTE. What we would do is staff between the 3 jurisdictions up north, us, Sun City, and Surprise. On 20 hours a week, we're going to work with each other to make sure that that unit is staffed. It may only be up 4 hours a day up in the northern area. The community health, these visits, these will be scheduled visits. We are not reacting to 911. We're making contact, and we're sitting down. From experience on the national level and even on the local level, the first visit can take 2 hours. So we aren't adding any FTEs. We're using existing resources, and the funding is designated to take care of any of those staffing costs, either at normal rate or overtime rate. The majority of the funding of the grant will go for those staffing costs.
So it'll be existing people that are on shift?
Yes.
Okay.
Yes.
No, it won't be adjusting
It
people
should
that are
be
shift.
shift, I'm
It'll
sorry.
be volunteers that will work on an overtime basis. So it won't affect our service delivery on shift. And we'll be sharing that load among the 3. And so the money for the overtime will come out of the grant, but that would be on a volunteer basis.
Okay.
with a maximum of 20 hours a week per.
I'll have to grab a calculator and work that through my head.
By the look on your face, Councilmember, should I try to clarify a little bit more? Because I think it is a bit confusing, but what they intend to do is allow paramedics, firefighter, EMTs to come back and work overtime doing this service. So it doesn't take away from any of the on-shift personnel that would be responding to regular EMS or fire calls. The cost of these folks coming back on would be covered through the grant. So it's a relatively small amount of time that our staff would be investing in this program, but when it's done in a consortium of cities like that, it has the net result of being a fairly significant pilot.
I guess where I was kind of hung up a little bit on the math in my head was it was 20 hours a week per person, and there was 2 people that were doing it, so my math went to 40 hours a week at overtime rate, and splitting 125,000 5 ways seems like that would be eaten up pretty quickly at an overtime rate, I guess was my thought process on that. So I still don't have my arms around that, but I'm not going to hold this up for that. So,
Well, Chief, can you explain maybe a little better?
Yeah, no,
better detail to that?
Councilman Finn, we expect the money to last about 6 months. And so we have a lot of the services being donated, so most of the money will go for, small chunk of it will go for training, because some of the training will be developed with the existing staff. And so the majority of it will be going for staff going out on overtime. And so 20 hours a week, you're right, 40 hours with the 2 vehicles, north and south, it will last us about 6 months.
So if you don't mind, I have one other question, if you don't mind.
Sure.
Can you help me understand, it was a great high-level picture of that, but can you tell me what that would look like? For example, if I were one of these individuals and I was admitted for a health issue, maybe it was a stroke or something like that, what would I see in this personally? What would happen with me?
You would see a visit from this unit that would come to your house, get your history, find out the medications you're on, get the whole history. It could be done after that with a phone call or a periodic visit, and making sure that you have your medications and look at alternative places that you could go to instead of going to the hospital and using the system. If you're not feeling well, then we would suggest that you go to the doctor, you go to a specialist, and get some follow-up that you may need. But the whole piece of it is to try to eliminate that use of the 911 system and the hospital system. Because as soon as you walk into the door of the hospital, you're costing the system $2,000 just to be checked in and not going through the whole system, where you just may need an adjustment of your medication and see either your primary or the specialist. And if you don't have transportation, we would connect you with an agency that could provide you that transportation to and from the doctor.
Okay, thank you.
Thank you. Councilmember Patena?
Thank you, Mayor. I have a couple questions. Chief Reese, so first of all, I find 12 to 15 911 calls a year extraordinarily high. But based on your comments, I can understand why. So let me ask this question. If a person calls 911 because they can't find a way to get their medication, or perhaps they can't afford their medication, and the paramedics come out to that house, what do they tell this person? Do they transport them to the hospital? Do they try to help them get their medication? What do they do at that point?
Well, again, this is a prevention program, so we know who those people are. And again, 10% will amount to us to 10 or 12 people in the city of Peoria. So 10 and 12 people in Peoria, and then if you look at Sun City and Surprise, you're looking about a maximum of 30 people that we will visit and be in contact with throughout that 6-month period during that study. And then the first time that we go visit is probably the most lengthy that we're going to spend with you, for example, to do the analysis as to what is your issue, what kind of disease you have, and what your medications are, how often do you take them, and what kind of signs, symptoms are you getting, and how often, and again, trying to prevent in a different method from you having to go to the hospital and getting care that could be done in a different fashion. And so that's what we're trying to accomplish.
Okay. And so I'm assuming that this program is proactive in terms of the paramedic going out and trying to figure out what kind of resources these people need to get their medication or to get them on track and whether they can see a doctor rather than going to the hospital. And so let's say that the person can't afford their medication. What would happen at that point? Would the paramedic that's on site attempt to find them resources to be able to do this, or would they try to head them in the right direction of where they might be able to go to either have someone help them pick up their medication or purchase their medication or whatever their issue might be? Is that something that they would be doing?
Councilman Patana, yes, it's all the above, is
Okay.
finding, and part of the training will train the EMS personnel, the paramedics, as to the resources available to them.
Okay.
So if it's dial-a-ride, if it's an agency that provides medication for that individual, and so there's just a myriad of resources out there that these individuals can utilize but don't know.
Okay.
And a percentage of them are behavioral health. And so directing them to a behavioral health center in lieu of going to the hospital and then giving them some medication and then sending them home, and then, again, not dealing with the crux of the problem.
Okay, thank you.
Vice Mayor Binsbacher.
Thank you, Mayor. Chief Ruiz, it could be, if I'm understanding correctly, someone is released from the hospital, they're given their instructions, they go home and they don't follow their instructions, and it becomes a 911 call. Through this process, you could find out that that person can't read those instructions. It could be that simple, that they just can't read those instructions, they don't know how to read, and so they don't follow those steps because they don't know how to read. And in many cases, they're not going to tell the doctor at the hospital that because it's a very uncomfortable, threatening situation. But when they're in their home and the firefighter comes in and it's a non-threatening situation, that's where you can get simple information like that. So it doesn't necessarily reduce the number of calls that you run, but it changes the nature of the calls to where you're managing these in a proactive way. Is that right?
It can be right, is our goal is to reduce those number of calls that we go on. And again, on a long term, and again, this is a study, so hopefully the study will turn out to be more of a longer term where we can call and just make a phone call and check with the individual, and we already know the history of the individual. Most of the time we know the individuals by first name anyway, and so you're making a phone call and checking with Mrs. Smith, make sure that her medications it's 30 days and it's time to refill, to make sure that that's happening. And again, you compound that with a myriad of situations. One category is post-surgical procedures. And so they go to the hospital, and I've had knee surgery not too long ago, and I found myself right after the surgery lecturing the nurse for about 15, 20 minutes on the adverse use of Percodans, and that I wasn't crazy about Percodans. And so by the time I got home, I was still fuzzy, and I wasn't going to read all the stuff they gave me. So this will help with some of those that we know that just had some post-surgery, and we get the information from the hospital. That's kind of the long-term goal. But some of these patients that we go on are in some kind of senior care, independent living or dependent living, and don't have any family. And so they rely on the center to take care of them, and sometimes it doesn't happen. And so the center ends up calling 911 on a regular basis. And so part of this would be to also educate those centers as to some of the alternatives available to them out there.
Thank you. My other question is, so I think this is great. This regional approach is a fantastic way to start. I think working in partnership with other departments is great because it shares that responsibility and whatever risk might be involved. But it really does create some, just takes the career opportunity to a whole nother level, I believe, with the department and new recruits and the training and the development, and because you're reacting to emergencies. And so this changes this is a tremendous culture shift to where you're no longer reacting, but you're being proactive, which means the mentality of the firefighter, the paramedic, or EMT changes dramatically because it's no longer how quickly can I get in and out and service and respond to this emergency, but then becomes this relationship and bedside manner. So, which is great, again, creates opportunity to really elevate the career path, which I think is fantastic. How do you determine which volunteers? Do you pre-qualify them, or can anyone volunteer for these shifts, or is it specific individuals that are really ready to step up and take this on?
Vice Mayor Binsbacher, for the pilot, we're looking at consistency. This is a 6-month project, so we are looking to select certain individuals. We're looking to look for volunteers. We've had quite a bit of interest expressed.
Great.
And then we want to train those specific individuals who would cover that shift and be consistent in the care delivery. They're also going to be charged with collecting a lot of data and accurate data for us in putting that into the system. So for this pilot project, that would be the focus. It's a small group that would be consistently representing us in delivering the community paramedicine.
Okay, great. Thank you. Very exciting.
Can you tell me about the program that Mesa has had in place for a while, and if that's similar to this?
It's similar, however, they shifted their focus to behavioral health. Is they got, what was it, it was a nearly, I think it was $400,000 grant to study the effects of trying to keep people out of the hospital because they're behavioral health patients. And so their program is focusing solely on behavioral health. And they're doing similar things, is that they go out and they visit with these patients and make sure that their medication is being kept up, that sometimes they want to talk to somebody, they're lonely, and that there's volunteers out there that provide that kind of service. And so that they're connecting them with them, and then that they're transporting them to behavioral health centers instead of the hospital. So it's a little bit different focus, but again, I think everybody's looking for a different approach, because when the paramedic program first started, it was always attached to the hospital. And so the paramedic went out and treated, and they were going to take them to the hospital. And so to break that paradigm, it's taken some time, and so the hospitals are now breaking at the seams and can't handle all these patients, so they're struggling for alternatives. We're struggling for alternatives of a cheaper way to go out and reduce our call volume. So we're trying to put ourselves out of business. Haven't succeeded yet.
I'm sorry to say you probably will not do that. Okay, I have one more question with regards to equipment, the vehicles that the paramedics or what will they be called? Paramedics? EMS? Okay. So what will they use to go there? Will they be in a engine?
No, this will be I believe, a Suburban SUV-type vehicle. Sun City has an extra vehicle, and it already is equipped with the CAD computer and the radios that would be available to us, so I think they're contributing in kind that vehicle. Long-term, you look around the nation, we see them in everything from hybrids to SUVs delivering community paramedicine. So it is 2 people that would respond, and we think an SUV-type response is appropriate.
Wow. Okay. Any other questions, council? No? All right. Well, this is really exciting. It's the dawn of a new day, isn't it? Wow, big things are happening. We have to be very innovative. So keep up the good work. Thank you.
Thank you, Mayor, Council.
Thank you, Mayor, and that's all we have in study session.